So the clinical context in which this work was being conducted is based on the fact that we already have evidence showing that patients who have breast cancer diagnosed during pregnancy and in the postpartum period do have diseases that are associated with more aggressive behavior. And that's thought to be related based on other studies with changes in hormone levels, immune infiltrates, and even cytokine profiles that occur not only during pregnancy, but also during the involution period that occurs in the postpartum period. And we know now that gene expression profiles such as Oncotype recurrence score have become an important part of our treatment decision-making process in patients with ER-positive, HER2 negative breast cancer. But we don't know how much these are informative in patients that are diagnosed during pregnancy, have breast cancer during pregnancy or in the postpartum period, which is particularly an important question because in these populations, especially in pregnant patients, we have particular restrictions in terms of the types of therapies that we can use. For example, we cannot use endocrine therapy during pregnancy. So the questions we tried to address in this study were if the distribution of the recurrence score measured by the 21 gene score changed based on the pregnancy status, and if this genomic score was also the prognostic value of this genomic score was sustained in this population. In order to study that, we queried our prospective cohort study called Young Women's Breast Cancer Study that enrolled a prospective cohort that included over 1,000 women that were diagnosed with breast cancer under the age of 40 years old. And then we included in this analysis patients with stage 1 to 3 ER-positive, HER2 negative breast cancer. And what we were able to show is that the distribution of Oncotype recurrence score did vary based on the pregnancy status. Particularly, we saw that patients that were diagnosed with breast cancer during pregnancy had high recurrence score, as well as those during the postpartum period when we compare them with patients that were nulliparous. And the preliminary analysis that we did looking at the prognostic value of the biomarker, we did have reassuring findings suggesting that the prognostic value of this biomarker is indeed sustained in this population. This is particularly important. The two key findings that we described in these posters, in these abstracts, were that they really suggest that there is a biological difference associated with this population of patients with the diagnosis of breast cancer during or right after pregnancy. And now next steps for us would be to confirm this prognostic value and then to try to understand the biological characteristics that are actually driving this more aggressive behavior in this population.